it has not been discussed in physiology. So today we will, I will try to touch physiology, some aspect of physiology also, physiological aspect of the thyroid hormone in very brief, okay, whatever is required from pharmacology point of view, okay. So shall I start?
Yes, sir.
Yes, sir.
Okay, so thyroid. Okay, thyroid hormone are secreted from thyroid gland. Okay, this is one of the important gland which control the normal growth and development and energy metabolism, and all these are controlled through its hormone, the thyroid hormone. And when we talk about the growth, okay, even growth hormone, it was controlling the growth, physical growth of our body. But remember, this thyroid hormone is also important for the development of neuronal tissue or brain growth, okay. So that is why in deficiency you will be in deficiency of these hormone, especially in infant, okay, newborn babies, it lead to mental retardation, okay. While in growth hormone, we have said that the mental growth will not be affected. So that is basically a difference between the growth affected by the growth hormone and the thyroid hormone. Okay. So when we talk about the thyroid gland, okay, its functional unit of the thyroid gland is follicle. Okay. Like when we say kidney, the functional unit is nephron, isn't it? Similarly, in thyroid gland, the basic functional unit is follicle or achinus. Follicle, what is this follicle? Follicle is filled with thick colloid containing thyroglobulin. Okay. So the follicle, what is follicle? It is a colloid containing okay, thyroglobulin, which is surrounded by a single epithelial cell, or what we say lumen. A one layer of lumen, it will have the colloid inside that. Okay, and that is what is said follicle. Okay, and what is this thyroglobulin? Thyroglobulin, it is a glycoprotein, a large glycoprotein which contain 115 tyrosine residue. Okay, so tyrosine residue are there, and that makes a thyroglobulin, and that thyroglobulin is present in colloid, okay, which is surrounded by a lumen. So that is what is thyroid gland. Okay, and this is what is we can what we discussed is this one thyroid gland. It is a follicle. Okay, so a single lumen, single cell luminal cell is there, just one cell, and here inside this is colloid. Like here, what is shown? This is a colloid. Okay, which contains the thyroglobulins, and this is one single layered cell, okay, and that is follicular epithelium. So this is one functional unit of thyroid gland, okay. So next unit. So these, all these units make the thyroid gland, okay. And in thyroid gland there is not only this, there is a parafollicular C cells also, this one, okay. Of course there will be red blood cells which is shown here. Okay, so this is the functional unit, and today we will be more concentrating on this unit. Okay, a single layered follicular epithelium, which inside which contains a colloid where there is thyroglobulin, a big molecule, okay, is there. So what are the hormones being secreted here is the thyroxine, or what we say T4, and triiodothyronine T3. Okay, this is produced by the thyroid gland, especially this follicles. From these follicle, what is released? The hormone is T4 and T3, or what we say thyroxine and triiodothyronine. And this parafollicular C cells, these cells releases calcitonin. This is also the hormone, and this hormone controls the calcium balance in our body. Okay, so this is, even though these three hormones are released, but when we say thyroid hormone, that means we are talking about this thyroxine and triiodothyronine. So these two are said to be a thyroid hormone, and today we will be talking about these two. This calcitonin, okay, even though it is released by thyroid gland, but from the other cell, the parafollicular cell, and it controls the calcium metabolism in our body. So that will be this calcitonin we will talk in the next chapter, that is the balance of calcium balance in our body. Okay, so calcitonin will be discussed there, and thyroid hormone, what we say is, this is all about T4 and T3. Today we will be talking about that. Okay, got it? Yes?
Yes, sir.
Yes, sir.
Okay, so very simple, isn't it? A thyroid gland, the functional unit is this, and which is covered by a single layer cells, follicular epithelium, what we say, and it contains a colloid where there is thyroglobulins. Okay, so now how this thyroid hormone is controlled, okay, or release is controlled. Now hypothalamus is there, okay. Hypothalamus releases thyroid releasing hormone. When this is released, a TSH, the anterior pituitary gland is stimulated, and then it releases thyroid stimulating hormone. This hormone act on the thyroid gland and releases the thyroid hormone. Okay, that is T3 and T4. Okay, so this is how it is released. So hypothalamus, TRH, thyroid releasing hormone. Okay, it will stimulate anterior pituitary gland to release thyroid stimulating hormone, and this thyroid stimulating hormone will stimulate the thyroid gland to release the thyroid hormones. Okay, similarly hypothalamus also, this the somatostatin, which is released from hypothalamus, also controls this TSH. It has, okay, this somatostatin not only control the growth hormone or say the prolactin, but it also has effect on the this thyroid hormone secretion. Okay, somatostatin, it inhibit TSH, it inhibit anterior pituitary gland to for, okay, not to release thyroid stimulating hormone. So this balances the release. Okay, and this TSH, when it is released, I have already said, when TSH is released, it will stimulate the thyroid gland, and thyroid gland will release T3 and T4. Okay, and these are the, basically we say it as a thyroid hormone, and this hormone produces the effect are produced directly as well as indirectly. Okay, so this is how the effect is produced, and the regulation of this thyroid is done one with the somatostatin. It checks the okay, release of thyroid stimulating hormone from anterior pituitary gland. Not only that, even this T3 T4, when it is released, it sends a negative feedback to the anterior pituitary gland, and that inhibit the release of thyroid stimulating hormone. Similarly, this thyroid hormone also inhibit hypothalamus, okay, or send a negative feedback so that thalamus will not release TRH. So this is how the thyroid hormone is balanced in our body. When there is requirement, then hypothalamus releases TRH, and this TRH will stimulate anterior pituitary gland to release TSH, and this TSH will stimulate thyroid gland to release the hormone, and the effect will be seen. When there is deficiency, this is what happens. When now once it is released, then it send a negative feedback to anterior pituitary gland as well as hypothalamus not to stimulate the thyroid gland. Okay, ultimately the hypothalamus or say anterior pituitary gland, ultimately they are stimulating this. So this is, apart from that, even somatostatin also has negative effect on anterior pituitary gland. Okay, so this is the regulation. In this is again the same thing shown in a diagram way so that you can remember. So hypothalamus releases thyroid releasing hormone into the blood, and through blood it comes to anterior pituitary gland, and then in anterior pituitary gland is stimulated with TRH, and then the pituitary will release TSS, thyroid stimulating hormone, and it will ultimately stimulate the thyroid gland, which is present in neck. Okay, so here the thyroid gland will be stimulated. This is a functional unit of a thyroid gland. Okay, and when it is stimulated, it releases the thyroid hormone, that is T3 and T4. Okay, generally this T3 is an active form of thyroid hormone. Okay, so whatever is released in T4, it has to be converted to T3, and that is what we say peripheral conversion also. So this ultimately this T3 produces the axon. Okay, mostly this is more potent, so it produces the peripheral axon. So what are the axon? We will talk briefly. Okay. So before that, let us talk about the synthesis, because once we know the synthesis, how it is synthesized, then it will be easier for us to understand how these synthesis or release are inhibited by antithyroid drugs. Okay, when thyroid hormones are more in our body, at that time we have to inhibit the release. So to understand that, we have to know this synthesis, and I have already said the detail will be covered in physiology, but whatever is important from pharmacology point of view, I will be talking about that, since it has not been covered in physiology. Okay, so in physiology you can revise these all things. So the synthesis and release of hormone takes place in these 5 steps. The first step is to take the iodine from the blood. Okay, and that is done by the follicle cell, the single cell luminal cell, isn't it? What I that take the iodine, and that is what we say iodide trapping. So it traps the iodine. Okay, and after trapping it, then this iodine is oxidized. Okay, and then the tyrosine, in thyroglobin there are the residue of tyrosine, what we said. So this tyrosine will be the iodine will be oxidized, and that tyrosine will be iodinated. Okay, which we say organification, or sometimes we say iodination. So in physiology they may say organification, that means the same, iodination. So this iodine is oxidized, and that oxidized iodine will iodinase the tyrosine. Now that tyrosine which is iodized um, uh, is coupled. There is a step said to be a coupling. We will discuss. Okay, a little detail about the coupling, and then after coupling, these all hormones are stored. Okay, and whenever there is a requirement, it is released, and the requirement is being sensed okay, by the hypothalamus anterior pituitary hormone, and that is why anterior pituitary hormone will secrete thyroid stimulating hormone that will cause the release of the thyroid hormone. So they will be released, and this released thyroid hormone, generally there is T3 and T4, and I have already said that T3 is the more active component. So that is why whatever T4 is released, that will be ultimately converted to T3. So that is why there will be a peripheral conversion, and this is also very important from pharmacology point of view. Okay, why you will understand once we discuss the antithyroid drugs. Okay, so these are the 5 steps how the hormone is synthesized. Now let us talk these step one by one. Okay, so this is this figure uh, uh, talks a lot about the synthesis and release. Okay, in a very good diagram is there. So this, there is a channel. Now this is a single lumen, the follicle cell, single cell is there, isn't it? Um, uh, Around in a functional unit of thyroid hormone, that is what we said. So here say this iodine is trapped or taken up by the cell. This is facilitated by the carrier, okay, which is said to be sodium iodine carrier. Okay, so this carrier will help, okay, in taking the iodine into the cell, and this is ultimately released in the follicle lumen. Okay, in lumen it comes, and then here what happens, there will be oxidation, and after oxidation, this is thyroglobulin. I have said the thyroglobulin, a big molecule which has a tyrosine residue, isn't it? So these are the residue. So this is oxidized, the iodine which is taken is oxidized, and then that oxidized will iodinate this residue. Okay, if one molecule of iodine oxidized, then we say mono MIT. Okay, that is this M stand for mono or single. Similarly, DIT. Okay, D stand for di. Diiodo iodo compound, okay, tyrosine, diiodotyrosine. So this is how it is iodized, and this is said to be the organification or say iodination. Okay, and after when this is formed, now this two molecule, di means two and mono, m means mono, one molecule. If these two combine, then what happens? 2 and 1, 3. So T3 is formed. Okay, when these two combine, and this combination happen on this thyroglobulin only. Okay, this thyroglobulin facilitate this process. Okay, and if the two di compound is coupled, or they come together, join, and it forms T4. Okay, that process is said to be coupling. Okay, and that is how T3 and T4 is formed in thyroglobulin only. Okay, and along with this, the thyroglobulin along with T3 and T4 may store it over here, or it is taken by the cell, and that is what we say endocytosis. It takes the cell and is stored here. Okay, endocytosis, it is stored here. And when TSH come, okay, when TSH stimulate, okay, this thyroid hormone, at that time there will be lysis, okay, and T3 and T4 will be released from this thyroid gland, and while this MIT monoiodotyrosine and diiodotyrosine, they are again utilized. From here the iodine is separated and this iodine again comes here. Again this process repeats. Okay, so this is how the synthesis happen. So iodine is taken and then it is iodized, and this iodized with iodinate the tyrosine residue. If one iodinate, then we say mono MIT. Okay, and if two, then DIT, the diiodotyrosine. Okay, monoiodotyrosine, diiodotyrosine, and these two, mono and di, when they combine, they form T3. That process is said coupling. Okay, and when two di, okay, that means two molecule of two iodine combined, they form a T4. Okay, and remain here in thyroglobulin, and which is stored either in follicle or inside the follicular cell with the by the process endocytosis, and whenever there is a requirement, it is released. T4 and T3 are released. Okay, so okay, so iodine trapping, the first step. Okay, so that carrier protein in that diagram, I showed there is a carrier protein, isn't it? So that is NIS, sodium iodine symport. It carries sodium and iodine in the same direction. So that is why we say symport. Okay, there are various carrier protein you might have that might have been discussed in the physiology. So anyway, so it is an energy dependent process, and it carries the iodine in against the concentration gradient. That means even though the iodine concentration is higher inside the cell, but it carries iodine from plasma where there is less iodine, from plasma to the cell, and it concentrate there. Okay, so against the concentration gradient it does. And this trapping mechanism is also present in other gland, in our other tissues also, but in other tissue it is not stimulated by TSH. Only the follicular cell. Okay, that means in thyroid gland only TSH affect this. When TSH come, this process, the iodine trapping process, become the faster and efficient. Okay, more iodine are trapped by these mechanism in presence of TSH. Okay, so thyroid stimulating hormone. So that is why this is important in synthesis and release of thyroid hormone. Okay, and once it is taken into the cell, okay, as discussed in the previous slide, so this is iodized to iodinium ion. So this is iodized, the iodine is converted, is oxidized. Okay, and this process, the oxidation is helped with hydrogen peroxide, and it is catalyzed by the enzyme peroxidase enzyme. Okay, this enzyme is important for the iodination. Okay, and the drugs which we use in case of hyperthyroidism, when there is more thyroid hormone, we want to decrease the concentration, we use a drug, and the antithyroid drug, they inhibit this enzyme. Okay, so we will talk about that in the antithyroid drugs. So anyway, so this is catalyzed by peroxidase enzyme. Okay, this enzyme also help in other. So this iodized, the oxidized iodine will combine with tyrosine residue in thyroglobulin to form monoiodotyrosine and diiodotyrosine. Okay, like what we discussed here. Okay, so this NIS, okay, sodium iodine symport will bring inside, okay, and then this will be now here. This is iodized. I have already said iodized, okay, and that iodized iodine, that means I plus, will cause iodination of this tyrosine residue to form MIT and DIT. Okay, and these all happen in thyroglobulin only. This, okay, so that is what we discussed here, isn't it? So thyroglobulin form MIT and DIT. Okay, now, so this is oxidation one step, which is helped by hydrogen peroxide and peroxidase enzyme, and then this this organification. This is also helped by the same enzyme, peroxidase enzyme. Okay. Now, coupling means when MIT, okay, and DIT, one molecule and two molecule, when they couple together, they combine together, they form T3. And two DIT, okay, diiodothyroidine, one and next two, when they combine, two iodine, that means four, okay, so that will form T4. Okay, and this process is said to be coupling, okay, to the tyrosine, iodinated tyrosine molecule combine. So, and this, all this coupling take place in and facilitated by thyroglobulin. It is not different. Okay, so thyroglobulin will help, and the same enzyme peroxidase facilitate this process. So, if you inhibit the peroxidase, the iodination, organification, or say the oxidation, iodination, and coupling are affected. So that is the drug which affect this, we say as anti-thyroid drug, okay, medicine. Now, storage and release, as we have already discussed, it is stored as colloid in the interior of follicle. Either it is stored in the follicle itself, or it is with endocytosis, okay, inside the cell. It could be stored, okay, and it is released on stimulation by TSH, thyroid stimulating hormone. When it is released from the anterior pituitary gland, then there will be released this, and that is facilitated the lysosomal protease that break down, okay, that break down this, and then the T3 and T4 is released, and simultaneously at the same time MIT and DIT are also released, which is deiodinated and utilized. Okay, so utilized for, again, that iodine will be free, and that iodine will enter inside the follicle, and again that same iodine oxidation, and then the iodination happens. Okay, so T3 and T4 is released in such a way. So TSH, the thyroid stimulating hormone, has a very important role in not only in the synthesis but also in the release. Okay, it also has a very important role, okay, because NIS, okay, sodium iodine symporter is stimulated by this, so more iodine will be trapped in presence of TSH, so synthesis will be more, and T3 and T4 will be released. Okay, so this is now that T3 T4, okay, which is released, especially the T3 is released in very low concentration, okay, in low amount, but remember this T3 is the active form. This is the hormone which produces the action T3, okay, immediate action. Now this T4, which is released in a high concentration, is converted to T3, okay, with the help of enzyme iodothyronine deiodinase. Okay, and this conversion is generally done happens in liver and kidney mostly. Okay, and yes, of course, there will be conversion of this T4 in brain and pituitary gland also. But what happens, this conversion, the converted T3 is not taken by brain and pituitary. What they do, they take the T4 from the plasma. Okay, they take, and then the conversion is done by themselves only, the brain and pituitary. Okay, so concentration of T3 is independent of that of concentration in plasma. Okay, concentration in brain and pituitary. So what they do is they take T4 and then convert it as per their requirement. Okay, so this is what is done, and this enzyme, okay, which facilitate the conversion of T4 to T3 are inhibited by these um, these drugs. Propyl thiouracil, we will discuss in next class. Propranolol, okay, you have already discussed, this is a non-selective beta blocker, isn't it? And generally when you give propranolol in high dose, then only this conversion is affected. Amiodarone, okay, amiodarone also you have read. What is, where you have read this amiodarone? Anyone?
Anti-arrhythmic.
Sorry?
Anti-arrhythmic drug.
Yes, very good. So it is anti-arrhythmic drug. So it also affect this conversion. So there will the conversion will be affected. T4 will not convert to T3. So the action of thyroid hormone will not be there. Okay, the thyroid hormone will be there, but the action will be lesser. Okay, glucocorticoid. We will talk in the corticosteroid chapter. Okay, so this all affect the conversion of T4 to T3. Okay. And now, now this thyroid hormone which is released, how it is transported and metabolized and excreted, let us have a look. Okay. So this thyroid hormone has high plasma protein binding capacity. Okay, and it is this T3, T4, they form a bond. Okay, they bind with the plasma and plasma protein, which the most important, most of the thyroid hormone they bind with this thyroxine binding protein which is present in plasma. Most of them they bind with this. Few they bind with thyroxine binding pre-albumin, and very less they bind with albumin. So this is in, you can say, decreasing order. Highest binding with this and lowest is with this. Okay, so whatever is released, okay, in the body, or sometime it is important pharmacologically also, when we take the thyroid hormone, okay, from outside, especially we take in the form of T4, they bound to the plasma protein, and slowly as per the free T3 concentration, it is slowly released in the plasma. Okay, so that is it bind with that. And the free hormone, they are metabolized by deiodination. Okay, the iodine is removed, and conjugation in liver, and generally it happens in kidney and salivary gland. Okay, so this metabolite also undergo enterohepatic circulation. Now if you see the T half, then it is T4 is longer acting. The T half of T4, okay, or thyroxine, what we say, is have 6 to 7 days half life, and T3 has just 1 to 2 days of half life. T3 is fast acting but a short acting, while this is what is long acting. It is converted to T3 and T3 will show the action. So anyway, T4 has long action. Okay, the T half is very long. T3 has a short, even though it is 1 or 2 days, but we say when we compare with T4, it becomes short. Okay, so talking about the regulation, I have already said that the hormone is regulated. The thyroid hormone is regulated from the hypothalamus. Hypothalamus release thyroid releasing hormone, and pituitary hormone will be stimulated, which release TSH, and this TSH will stimulate thyroid gland and releases T3 and T4. Okay, and this will give negative feedback mechanism. Okay, negative feedback to anterior pituitary gland and hypothalamus, which will lead to decrease in TSH. Okay, and there will be decreased stimulation of thyroid gland, and T4, T3 release will be checked. Apart from that, I have already said that there is a role of somatostatin, which inhibit the anterior pituitary gland. Apart from that, okay, these two you have to know. Dopamine also inhibit anterior pituitary gland to release TSS. So dopamine decrease the release of TSS from anterior pituitary hormone. Similarly, glucocorticoid also inhibit. And similarly, the concentration in the plasma concentration of iodine, when there is low concentration of iodine in plasma, there will be increase, the thyroid hormone will be stimulated. It gives the positive feedback, while low iodine gives negative feedback. Okay, so that is also important, and this is something important clinically, pharmacologically. Okay, so we will discuss this later also. Now, talking about the action of thyroid hormone, okay, thyroid hormone in the most important, it affects the growth and the metabolism in our body. Okay, so growth, it affects the growth, especially it also affects the neuronal growth. So that is why if there is deficiency of hormone, the thyroid hormone in infant or baby, there will be congenital deficiency, which will lead to mental retardation. Okay, because it affects the neuronal growth also. Okay. So metabolism generally, this thyroid have indirect action. It indirectly affect the metabolism. Ultimately, what does it do is it increase the BMR, basic metabolic rate. BMR, basic metabolic rate, is increased. Okay, so when thyroid hormone is less, the BMR decreases, and when there is more thyroid hormone, there will be more. Okay, so the clinical feature like will be like when there is hypothyroidism, you will find the person with the low BMR, basic metabolic rate, will be lesser. Okay, so in hyperthyroidism there will be more. So BMR, when basic metabolic rate decreases, the even the temperature in the body will decrease. So that is why they feel cold. The hypothyroidism person, they feel cold even in good weather. Okay, they are like even in hot season they will complain of cold, while there will be opposite. Okay, like in hyperthyroidism, there will be more metabolic rate, temperature generation will be more. Okay, so even they will sweat. Okay, in cold weather. So this is, and similarly it causes lipolysis. Okay, it breaks down the protein and increases free fatty acid. LDL level is decreased. Carbohydrate Generally, it increases the peripheral utilization. Glycogenolysis, gluconeogenesis is increased. Absorption is also increased, and there will be hyperglycemia because the thyroid hormone they increases the BMR for that. Okay, when metabolic rate increases, you can correlate all these action with the BMR also. Okay, and protein we cannot generalize whether it is anabolic or catabolism, but in general it is higher towards the catabolic side. Okay, and cardiovascular system, it directly also affect the cardiovascular system, especially the heart, and also indirectly. How indirectly? By increasing the sensitivity and number of beta receptor. Okay, beta 1 especially, their number and sensitivity is increased when there is thyroid hormone. So when there is number, the hormone, the receptor will be increased, then there will be more action. Okay, so there will be increased heart rate, increased contractility, and cardiac output, increased cardiac output. Okay, got it? Very remember, when there is deficiency, decrease of thyroid hormone, okay, then what happens? The sensitivity of beta receptor goes down, number goes down. So that is why the heart rate, pulse, blood pressure may decrease. Okay, while in hyperthyroidism, okay, that means when thyroid is more, that thyroid will causes more number of the beta receptor, the sensitivity will be increased, and that will affect the cardiovascular system. Okay, so basically it is causing indirect. It has some direct, but most important is this indirect action. So it doesn't do directly increase the heart rate, contractility. Okay, rather it will increase the beta receptor and increase the action. Okay, roll number 9, are you there?
Yes, sir.
Okay,
Yes.
so how does this thyroid hormone affect cardiovascular system?
So if the thyroid hormone is more, then it will increase the sensitivity and number of beta receptors, which will increase heart rate, cardiac output.
So the hormone uh, is affecting the beta receptor sensitivity and the number. Okay, so that is in skeletal muscle. Okay, it maintain the tonicity. Okay, the thyroid hormone is important. When there is hypothyroidism, the muscles become flabby and weak, skeletal muscle. While in hyperthyroidism, the tone increases. So that is why there will be, you can observe the tremor. Okay, in hyperthyroidism, there will be the symptoms of that. One of the symptoms is tremor also. And then due to overactivity on the skeletal muscle, there will be weakness also. Okay, so in hypothyroidism also there will be weakness in a muscle, and then even hyperthyroidism. So that is why the levels should be very optimum. Okay, and GIT, what happens is propulsive activity increases with hormone. Okay, the peristaltic movement or propulsive activity is increased. So what will happen if there is hypothyroidism? The thyroid hormone is less. Roll number 7. Roll number
Yes, sir.
7.
Yes, sir.
Yes. What will you expect in hypothyroidism?
There will be decrease in propulsive action.
Then what the
Due
patient
to
will
which
complain?
malabsorption of vitamins, nutrients.
The patient will complain of diarrhea or constipation?
Diarrhea.
Hypothyroidism.
Yeah, hypothyroidism, constipation.
Constipation, yes. So that is one of the symptoms of hypothyroidism. So to maintain the peristaltic movement also it is important. And then when hypothyroidism, there will be constipation. In hyperthyroidism, there will be not exactly the diarrhea, but the propulsive activity will increase. So you can expect that. Okay. So it also affect the hemopoiesis, okay? And that is why in hypothyroidism there will be anemia. So in hypothyroidism patient you will see the look of a patient will be pale, okay, pale looking skin you will observe, okay, hypothyroidism. In reproduction is also affected by thyroid hormone, okay, and in when there is decreased thyroid hormone, in case of hypothyroidism there will be impaired fertility, so fertility decreases, okay. So these are the actions of thyroid hormones which we uh, talking about the mechanism, how does it act? It acts through the nuclear receptor, okay? And I think in first semester, we have already discussed the types of receptor and nuclear receptor. So nuclear receptor is present in cytosol, not inside the nucleus, but in cytosol. So hormone cross the cell membrane. So that is why lipid soluble drugs, they act through this nuclear receptor because it has to cross the membrane and form a complex with a receptor in cytosol. And this cytosol, the complex then enter into the nucleus, dimerization, and then zinc finger bind with the thyroid hormone responsive element, okay, in a gene, and which ultimately affect the protein synthesis, okay. So the same mechanism we have discussed in first semester, so just a revision, okay. So if this is okay, thyroid hormone, okay. So the receptor is present in cytosol, not in a nucleus. This is a nucleus, so it is present over here. So what happens? This drug will cross the membrane and bind with the receptor, and then the receptor will be activated. Okay. Now these two finger-like projection will come. That is what we say zinc finger, and this will enter into the nucleus and particularly bind to the thyroid responsive element, the particular gene. It will identify, the zinc finger will identify and bind over here, and then it produces the mRNA and affect the protein. Ribosome will produce the protein, and that will cause the cellular function or the modifications. So this is how the thyroid hormone act, okay. And this is just a revision of first semester, okay. I hope you have understood, okay. I have not complicated the mechanism. I have tried to make it very simple, okay. When you read your books, it will be little bit complicated than what I have said right now, okay. So I think this is more than sufficient for your undergraduate level, okay. Now comparing about T3 and T4, okay. So T4 is secreted more, as we have already discussed, okay. And T4 has high plasma protein binding, and it is long acting and a slow acting. T4, it is long. We have already seen T3 just act for 1 to 2 days. However, T4 may act up to a week. Okay, so T half of that is up to a week. While T3 is more potent, more active, okay, and they bind more with the receptor. So that is why the activity is more, okay. Since they are free, so that is why they are more susceptible for metabolism. So that is why the short action. It has a fast but short acting, very important. If you want a fast action, you have to prefer the T3 preparation, okay. Ultimately, T4 which we gave is converted to T3 by peripheral conversion. We have already discussed about that also, isn't it? So T4 is converted to T3 and T3 will show the action. Now preparation what we have is L-thyroxine, that is levothyroxine, okay. In sodium salt it is available. This is the very most commonly used preparation for preparation of thyroid hormone. This is T4 preparation. T4 triiodothyronine, or levothyroxine, whatever you say, it is the same compound, and it is a formulation of T3. T3 formulation is triiodothyronine or levothyronine, while T4 is levothyroxine, and this is what is very commonly used one. Okay, the thyroid preparation. Uses of thyroid hormone, what are the uses? We use it in cretinism, that means in deficiency of the thyroid hormone, okay, especially in infancy and childhood. And remember, this in cretinism, there is the growth is suppressed. Not only that, there will be mental retardation also, which is partially reversible. So that is why, for a better result, okay, immediately we have to identify the deficiency very early and use the drug. If we do that, then we can reverse the mental retardation. Okay, so if it is delayed, then the mental retardation is not reversible one, so we will lose that. Okay, so the challenge in cretinism, management of cretinism, is to identify the deficiency early and then start the therapy. Okay. Adult hypothyroidism, we say when there is decrease T3 and T4, okay, and TSH level is increased. TSH level is increased and T3, T4 level is decreased, we say it as hypothyroidism. Okay, so this is adult hypothyroidism. In that case, we prefer the levothyroxine, L-thyroxine, that is T4 preparation. This is a T4 which we prefer, and it should be given in empty stomach for better bioavailability. Remember, this is pharmacologically important thing. Okay, and generally what we do is, as per how much deficiency is there, how much there is a decrease in T3, T4, what is the level of T3, T4, that determine what is the dose to be given. Okay, how much TSH has been increased. So generally what we do is, we start with the low dose, okay, because hypothyroid, it is not an emergency condition. We start with the low dose, maybe sometime 25 microgram once a day. Okay, in this 50 microgram is written, 25, 50 we generally start in low dose, and then we, after 3 weeks, remember, after 3 weeks only, before 3 weeks we don't repeat the test. After 3 weeks again we see, measure the thyroid function test, okay, measure T3, T4 or TSH level, and as per that we will decide whether to increase the dose or decrease the dose. Okay, if this is normal, then we can continue. If T3, T4 level is higher, TSH is lower, then we may have to decrease the dose also. Okay, so after 3 weeks we will decide, and if required, then we can increase the dose or decrease the dose. So remember, this increase, decrease or dose adjustment is done only after 3 weeks of therapy. Okay, so, and after 2 to 3 weeks, you will find a decrease in weight, and periorbital puffiness. Generally, you will see the puffiness in the eyes, okay, and pale face. Okay, so and in hypothyroidism, there will be weight gain. One of the symptoms of hypothyroidism, because BMR decreases, the basic metabolic rate decreases, isn't it? There will be constipation. Then there will be fat deposition below the skin. So all these causes, like what we say in hypothyroidism, there will be non-pitting edema. Okay, non-pitting, when you press the skin, the surface will not be pressed. So pitting edema is due to accumulation of the water in the body. Okay, so that is there. So weight increases, okay, in hypothyroidism. So when you start the therapy, slowly the weight will start decreasing. Okay, So, and it takes 2 to 3 weeks. Okay. So today we will stop here. I think two slides were left for today. Or shall I finish this? I think there is still 5 more minutes is there. I think we can finish, and in next class we will just revise it and then go to the antithyroid. Okay. So adult hypothyroidism. This diagram shows the puffiness, okay, all over these eyes, a pale looking face, okay, due to anemia. So this is the feature of hypothyroidism. Subclinical hypothyroidism, this is a term used where now TSH is high. In this case the TSH is high, but T3 and T4 are normal. T3 and T4, they are normal. If it is a case, we say as subclinical hypothyroidism. Okay. So in that case also we use T4 preparation in low dose, and after 3 weeks again repeating we repeat the thyroid function test and do necessary dose adjustment. Okay. Mixed edema coma, this is a hypothyroidism but severe hypothyroidism. So this is a coma, it is an emergency condition. Here we will be like the temperature of a patient will go down, so we have to increase the temperature. Okay. And the suppression of other is also there, so we have to use the corticosteroids and other symptomatic management we will do in this case. Apart from that, we can give levothyroxine, that is T4 preparation in intravenously. Okay. So it is a preferred one. You can think that okay, T3 could be given. This is a T4 preparation. T3 is fast acting, so since it is a coma, so you may want a faster action. But we don't prefer T3 because T3 when we use it has say side effect in the cardiovascular system. Or sometimes there is a defect in this system, the hypothyroidism, anterior pituitary, and then the thyroid hormone. There is something disturbance in the hormonal concentration. So in both the cases we can use, okay, excessive TSH. So in this case, when there is hypothyroidism, T3 concentration will be more. So it will the excessive TSH will cause a proliferation. So that is why the mass of a thyroid gland increases. So that is what is goiter. In that case, also we can use thyroid hormone. Similarly, thyroid nodules we can use. Okay, especially to decrease the level of TSH. Okay. And even in papillary carcinoma of thyroid, this thyroid preparation could be used. So this is all about the thyroid, and there are few MCQs. Okay, just 4 MCQs are there. Number one is the rate of secretion of thyrotropin, is TSH, in thyroid gland, amount of thyroid hormone in thyroid gland, concentration of thyroid hormone in blood, concentration of catecholamine in blood. Okay.
C.
Yes, C is the correct answer. Question MCQ number 2. Levothyroxine is used in which case? A, B, C, D. Which one is correct answer? B is correct answer. Okay, you can just check it after this class. And in treatment of hypothyroidism, thyroxine is preferred over levothyroxine because thyroxine is what? Which one is the correct answer? Is it a fast acting?
No.
No. Fast acting is T3. It is
Long
longer
acting.
acting. Yes. Okay. So that is, so B is the correct answer. And then question number 4, that patient of hypothyroidism was prescribed levothyroxine. Which of the following is most reliable guide for dose adjustment of thyroxine? So what is the most important thing is this option is D4. D is the correct option. We see the serum TSH level. Okay. So that is the correct answer, and you can briefly describe the management of adult hypothyroidism in next class. Please be prepared, and then we will discuss. Okay, this finishes the thyroid hormone. In next class, we will briefly first describe about we will revise the thyroid, and then we will enter into the antithyroid. Okay. Any questions? Any questions? Am I audible to you?